In this presentation, we will be talking about In this presentation, we will be talking about the updated AASM guidelines by 2015. The American Academy of Sleep Medicine is committed to ensuring that the AASM manual for the scoring of sleep and associated events reflects the best and most current evidence in sleep medicine. A scoring manual committee oversees the content and makes recommendations when content changes are indicated. Need for clarification exists. There is a new technology for the literature suggests that updates are needed. The updated manual was released 1st of July 2015 as version 2.2. All AASM accredited sleep facilities and home sleep accredited All AASM accredited sleep facilities and home sleep accredited testing centers programs are required to implement the new rules in version 2.0. All AASM accredited sleep facilities and home sleep accredited testing programs are required to implement the new rules in version 2.2 by October 1st, 2015. Based on the recommendations of the AASM Scoring Manual Committee, the AASM Board of Directors has approved the addition of 2 new sections to the manual. Sleep staging rules for infants and home sleep apnea testing rules for adults. So in the section of sleep staging rules for infants, we will discuss ages for which infant sleep staging rules should apply, technical specifications, general scoring of sleep stages, scoring stage for wakefulness, scoring stage non-REM, scoring stage REM, scoring stage transitional. So infant sleep staging rules should be used to score sleep and wakefulness in infants 0 to 2 months post-term, 37 to 48 weeks conceptional age. Conceptional age is gestational age at birth plus the number of weeks postpartum. Knowing an infant's conceptional age is crucial for interpreting the normalcy, immaturity, or abnormality of an EEG or PSG, because the brain knowing an infant's conceptional age is crucial for interpreting the normalcy, immaturity, or abnormality of an EEG or PSG, because the brain and the EEG continue to develop and mature at a similar rate independent of whether the infant is in utero or post-delivery. For connecting electrodes, for connecting EEG, EOG, and chin EMG electrodes, using the adult electrode derivations, are acceptable when recording sleep, except for the following. For chin EMG, the distance between electrodes often needs to be reduced from 2 cm to 1 cm. For connecting EEG, EOG, and chin EMG electrodes, applying adult electrode derivations is acceptable when recording sleep, except for chin EMG electrodes, the distance often needs to be reduced from 2 cm to 1 cm. And for EOG electrodes, the distance often needs to be reduced from 1 to 0.5 cm. In infants, it's recommended to use the following montage. In infants, it is recommended to use the following montage: F4M1, C4M1, O2M1, F3M2, C3M2, O1M2, For infants, the following montage should be considered: F4M1, C4M1, O2M1, F3M2, C3M2, O1M2, C4CZ, and C3CZ. Since sleep spindles are often asynchronous in children until 2 years of age, and may be more prominent in the midline central, therefore, simultaneous display of the recommended and backup electrodes and CZ midline central may be considered. Synchronized video and audio recording is highly desirable. Using synchronized video and audio recording is highly desirable. Using synchronized video and audio recording is highly desirable, especially that behavioral patterns are extremely useful for infants. Using synchronized video and audio recording is highly desirable, especially that the behavioral patterns for infants are extremely useful for the scorer. The following terminology should be used when scoring sleep in infants 2 to 0. So the following terminology should be used when scoring sleep in infants: stage wakefulness, stage N, that represents the non-REM sleep, which is analogous to the previously used terminology of quiet sleep, which is analogous to the previously used terminology of quiet sleep. Stage REM, that is analogous to the previously used terminology of active sleep. And stage transitional, that is analogous to the previously used terminology of indeterminate sleep. As in adults, we need to score epochs using the following rules. Score sleep stages in 30 seconds. Assign a stage to each epoch. If 2 or more stages coexist, assign the stage comprising the greatest portion of the epoch. If 2 or more PSD characteristics are discordant for stage REM or stage N sleep, score the epoch as stage transitional. Sleep onset is defined when we score the first epoch of sleep. Sleep onset is defined when we score the first epoch of sleep. Sleep onset is defined when we score the first epoch of sleep, and up until 2 to 3 months post-term, The first epoch of sleep in infants is often stage REM. Sleep and wakefulness in infants are scored based on the following characteristics: behavioral observation, Sleep and wakefulness in infants are scored based on the following: behavioral observation, regularity or irregularity of respiration, and EEG, EOG, and chin EMG patterns. This table summarizes the behavior characteristics respectively This table summarizes the behavioral characteristics. This table describes the behavioral characteristic per each sleep stage in infants. For stage W, the patient the infant is calm or active with eyes open, scanning eye movements, and brief eye closure can occur with crying. In stage non-REM, eyes are closed, few movements, and sucking can occur. Stage REM, eyes are closed, REM seen under closed eyelids, squirming, sucking, grimacing, small eye movements. In stage REM, eyes are closed, REM seen under closed eyelids, squirming, sucking, small movements of the face or limbs. The second table summarizes the respiration characteristics. The second table summarizes the respiration characteristics based on each sleep stage. The second table summarizes the respiration characteristics in infancy based on the different sleep stages. The second table summarizes the respiration characteristics in infancy based on each sleep stage. For stage wakefulness, the breathing pattern is irregular, rapid, and shallow. For stage non-REM, the breathing pattern is regular. For staging REM, the breathing pattern is irregular with some central episodes that may happen, and in stage REM, the breathing pattern is irregular, in stage REM, the breathing pattern is irregular, with the chance of having central pauses. In stage REM, the breathing pattern is irregular, with the occurrence of some central pauses. In stage REM, the breathing pattern is irregular, with the occurrence of some central pauses. In infants, the EEG pattern can be discontinued. In infants, the EEG pattern can be discontinued and can be continued. In this table, stage non-REM is scored when the EEG pattern is discontinued. In this table, stage non-REM is scored when the EEG pattern is discontinued by the appearance of the trace alternate. By the appearance of the trace alternate waveforms. By the appearance of the trace alternate rhythm that is characterized by at least 3 alternating runs of bilateral symmetrical synchronous high voltage bursts of delta activity alternating with periods of lower amplitude theta activity. When the EEG pattern is continuous, stage REM and wake are characterized when there is low voltage irregular waveforms. which is a continuous low voltage mixed frequency activity with delta and predominantly theta activity. In non-REM sleep and rarely in REM sleep, the high voltage slow activity can happen. That is defined as a continuous synchronous symmetrical predominantly high voltage 1 to 3 Hz delta activity. Stage REM and stage wakefulness can be scored if the EEG pattern shows low voltage irregular waveforms, which are defined as low voltage mixed frequency activity with delta and theta. Stage REM and stage wakefulness are characterized by the presence of the low voltage irregular waveforms, which are defined as continuous low voltage mixed frequency activity with delta and theta. Stage non-REM and rarely in non-REM the high voltage slow activity can appear. That is defined as continuous synchronous symmetrical in stage non-REM and rarely in REM, the high voltage slow wave activity can appear. That is defined as a delta activity with a voltage range of 1 to 3 Hz. In stages wake, REM, and rarely in non-REM, we might observe the mixed pattern. In stages wake, REM, and rarely in non-REM, the mixed pattern can happen. For stage non-REM, as a stage of as a waveform as a waveform of interest, sleep spindle is considered as a signature for scoring non-REM. And in infancy, sleep spindle is defined as 12 to 14 and in infancy, sleep spindles and in infancy, a sleep spindle is defined as a 12 to 14 Hz waveform that is more prominent in midline, central, and central derivations. This table scores sleep in accordance with the following definitions and based on the EOG characteristics as defined in the following table. So in stage wakefulness, the EOG should show eye blinks, rapid eye movements, scanning eye movements, which are defined as trains of conjugate eye movements with eyes open, consisting of a slow phase followed by a rapid phase in the opposite direction as the infant visually scans the environment or follows objects. Transient eye closures may be seen in wakefulness, especially when the infant is crying. In stage non-REM, the EOG should show closed eyes and no movement. In stage REM, the EOG should show closed eyes with rapid eye movements. Based on EMG patterns, sleep stages can be scored. Score sleep in accordance with the following definitions and based on the Chin EMG patterns as defined in the following table. For stage wakefulness, the Chin EMG should show present present tone and movement artifacts. In non-REM sleep, the chin tone is present and could be lower than wake. In REM sleep, the tone is low and transient muscular activity may occur. To sum up, stage W is scored based on the behavioral observations when we have eyes opening, crying, feeding, when the respiration pattern is irregular, when the EEG shows LVI or mixed pattern. When the EEG shows LVI or mixed pattern. When the EEG shows low voltage activities or mixed patterns. Based on the EOG, it can be characterized by the presence of the reading eye movements, blinks, scanning eye movements, and the chin tone is present. For stage N, based on the behavioral observations, if the movement is reduced in relation to wakefulness, eyes are closed, periodic sucking, when the respiration is regular, when the EEG shows TA, HV, when the EEG shows TA, HVS, sleep spindles, or mixed. When the EEG shows TA, HVS, sleep spindles, or mixed patterns. When the EOG shows closed eyes with no eye movements, and when the chin EMG is present, and when the chin EMG tone is present or lower than during wakefulness. For stage REM, when the eyes are closed with some small movements, respiration is irregular, when the EEG shows LVI or mixed and rarely HVS, when the EOG shows REMs or eyes closed with no eye movements, and when the chin EMG tone is low, where transient muscle activity can occur. For scoring stage transitional, score an epoch as stage transitional if it contains either 3 non-REM and 2 REM characteristics, or 2 non-REM and 3 REM characteristics. In this example, there are 3 characteristics of stage REM and those are the LVI on the EEG, the absent tone in chin EMG, and the irregular respiration pattern. However, there are two characteristics of stage non-REM, which are the no REMs and the absence of the behavioral movements. However, two characteristics of stage non-REM are seen, which are the no rapid eye movements and the absence of the behavioral movements. In this case, the epoch should be scored as a transitional stage. The second new section is talking about home sleep apnea testing rules for adults. First section is talking about the general parameters that should be reported when using the home sleep apnea testing devices. So it is recommended to document the type of the device, the type of airflow sensors, and here tidal volume sensors, for example, the ripsum and the ripflow, can also be used. Oxygen saturation, heart rate, body position, sleep, wake, or monitoring time as a method of determination. As this is one of Section A shows the general parameters that should be reported when using home sleep apnea testing devices. It is recommended to report it is recommended to report the type of the device, type of airflow sensor, and here the tidal volume sensors like the ripsum can also be used. Oxygen saturation, heart rate when it is derived from ECG or derived from pulse ox. Optionally, body position can be reported. Sleep, wake, or monitoring time also can be reported. However, sleep should be determined using EEG, EOG, and chin EMG recording. The method used to determine monitoring time should be specified in the report. Also, optionally, snoring should be monitored. And finally, snoring. This table shows the data that should be reported, recorded, this table shows the recommendations for the recorded data that should be reported. خلاص قص أختك خلاص. والله ريتك بالأعمال يعني يا ابن الحمار. So the following parameters should be reported. So the following parameters So it is recommended to report the following data: recording start time, recording end time, total recording time, including wakefulness and artifact, monitoring time, which is the total recording time minus periods of artifacts and time the patient was awake as determined by actigraphy, body position sensor, respiratory pattern, or patient diary. The method used to determine movement time should be stated. And it's optional to record total sleep time. That assumes monitoring EEG, EOG. كس أختك أخو شرموطة. And optionally, total sleep time in minutes is recorded. This assumes monitoring EEG, EOG, and submental chin EMG. Heart rate statistics is recommended. Number of respiratory events is recommended. Number of apneas is recommended. Number of hypopneas is recommended. Number of obstructive, central, and mixed apneas is optional. Respiratory event index based on monitoring time is recommended. AHI is recommended. REI or AHI in the supine and non-supine position is recommended. REI or AHI in the supine and non-supine positions is optional. Central apnea index is optional. A measure of oxygen saturation, one of these three parameters, is recommended. as reporting all three parameters may provide important information for the clinician. Oxygen desaturation index for more than or equal to 3 or 4% should be reported. Oxygen desaturation index should report the same desaturation as used for scoring hypopneas. For example, if hypopnea is scored based on a more than or equal to 3% desaturation, the oxygen desaturation index should be the number of the more than or equal to 3% desaturations multiplied by 60 divided by monitoring time. Occurrence of snoring, if recorded, it's optional. In the summary statement, date of test and date of interpretation is recommended. Technical adequacy of study is recommended. Document repeat study for technical failures. Limitations of study is recommended. Interpretation of REI. Interpretation of REI or AHI is recommended. Occurrence of snoring is recommended. Interpretation is recommended. Study supports diagnosis of OSA or not is recommended. Diagnostic severity is recommended. If it is non-diagnostic study, recommend. If study is not diagnostic, recommend in-center PSG if clinically indicated, and that is recommended. Printed name and signature of interpreting physician is recommended. Recommendation for management that meets AASM clinical practice guidelines is recommended. Chain of custody, if applicable, is optional. In terms of technical and digital specifications, a home sleep apnea testing equipment should have the following features. FDA approval of device, unique identifier for each unit, must meet minimum definition for CPT codes, ability to record oximetry, ability to record a measure of heart rate, and ability to display raw data for review, manual scoring, or editing of automated scoring. Ability to calculate a respiratory event index and AHI index. Ability to determine chain of custody, and that is optional. For scoring respiratory events in home sleep apnea testing studies, the following rules should be applied. For identification of respiratory events based on respiratory flow during a home sleep apnea testing, if it is diagnostic, at least one of the following sensors should be used. Oronasal thermal airflow sensor that is sensitive for apnea, nasal pressure transducer that is sensitive for hypopnea. Alternative sensors include rip flow, rip sum, PVDF sum. PVDF sum is acceptable. PVDF sum is acceptable. Oronasal thermal airflow sensor that is sensitive for apnea. Nasal pressure transducer with or without nasal pressure transducer with or without square root transformation is recommended for scoring hypopnea. Alternative sensors include respiratory inductance plethysmography, rip sum or rip flow, and PVDF sum, which is acceptable. For monitoring respiratory effort, use one of the following technologies. Single or dual thoracoabdominal rib belts, this is recommended, and the acceptable techniques are the PVDF belts, piezo belts, and using the pneumatic belts. Single or dual thoracoabdominal rib belts, this is recommended. Single or dual thoracoabdominal PVDF belts, this is acceptable. Single or dual thoracoabdominal piezo belts is acceptable, and the pneumatic belts as unacceptable. And single or dual pneumatic belts, which is acceptable. For monitoring oxygen saturation, use pulse oximetry. The recording device should meet the same requirements for oximetry. The recording device should meet the same requirements for oximetry as the in-lab PSG. For snoring, use an acoustic sensor, piezoelectric sensor, and snoring that is derived from the nasal pressure transducer. The last section is about utilizing peripheral arterial tonometry in home sleep apnea testing. So the peripheral arterial tonometry is a device that can be used to evaluate arousals peripheral arterial tonometry is a technique that can be used to evaluate arousals induced by obstructive sleep apnea syndrome based on the sympathetic activity during sleep. And for identification of respiratory events based on the PAT technique, the peripheral arterial tone should be used together with oxygen saturation and changes in heart rate derived from oximetry to document and score respiratory events. So for identification of respiratory events based on the PAT, for identification of respiratory events based on peripheral arterial tone during For identification of respiratory events based on peripheral arterial tone during a home study apnea test, use peripheral arterial tone, oxygen saturation, and changes in heart rate derived from oximetry. For monitoring oxygen saturation, use pulse ox. For monitoring oxygen saturation, use pulse oximetry. Thanks for your attention.